All right, folks, so we're hitting 4 o'clock, so we'll go ahead and get started. Thank you, everyone, for joining. My name is Chris Thom, one of the emergency medicine faculty members at the University of Virginia, and I have the great pleasure to talk to everyone about MSK ultrasound, in particular, fracture identification. And so there's a lot of excitement in point-of-care ultrasound. There's a lot of new emerging fields. You've, I'm sure, heard a lot about transesophageal echo. There's a lot recently about carotid artery pulsation during cardiac arrest. Regional anesthesia is very much an up-and-coming area. Transcranial Doppler is sort of sneaking around the corner every now and then, raising its head, right? But my hope with this talk is sort of wave the flag for the fracture indication and that particular MSK indication as an area that perhaps has enough literature now and enough support behind it that it could be time, at least for certain applications, certain patients, certain bones, it could be time to think about it in your practice. So that's kind of the goal, and that's sort of the 30,000-foot view. Now, our institution, University of Virginia, receives grant funding through a collaboration with Ravana Medical, which is a ultrasound manufacturer in Charlottesville. So that goes to the institution. We're going to talk about a few things. Number 4 and 5 on this list, we probably are not going to talk about. Those were sort of aspirational goals, depending on the timing. But we're going to focus in on the first 3. And I think bone ultrasound is an interesting prospect because you can look at this one of 2 ways. And it's truly, is the glass half full or is it half empty? So one side of this is, hey, there's this thing, it's in my way, my ultrasound beam hits it, I hit a complete dead end, I can't see anything below it, I can't get to my heart because of these things. And that's one way to look at it. The flip side of that, though, and it's the same virtue of that highly echogenic surface is because you have such a good reflection, you tend to get very clear, high-quality pictures of that bony cortex. So you can look at it either way. It's perhaps a personality test or however you want to look at it. But example, this is a minimally displaced or slightly displaced sternal fracture. So really nice, clear view of that bone, clear view of the disruption, and we can talk about when it changes management and how it helps, but at least able to see that bone nice and clearly. There's a lot that ultrasound manufacturers can do to help highlight the bone. Some of this is easy to think about. Some of this is a little bit more complex. The example here is a pre and post-processed bone image. And what you can do is you can basically put together post-processing software that says, okay, great, anytime I see a highly echogenic surface and a shadow, I want to highlight that highly echogenic surface and tamp down the rest of the image. That's fairly simple to do, and folks can do that. AI makes this a lot more interesting if you think about it, because now you can label up, let's say, 100 distal radius examples, send it into an AI algorithm to get trained on. That AI algorithm will start to recognize features of that images associated with that distal radius that you might not even have thought of or been aware of. And then when it goes to validate or when it goes to look at another data set, it may use those in the background to help. Other things that have been done, I think this one is interesting, sort of the tomographic view, almost like a CAT scanner, where you've got your ultrasound probe circling, if you will, taking different shots of the anatomy and then putting it together in one single image. Very similar to a CAT scanner, very interesting. There's been a lot done with 3D ultrasound and fractures. There's just 2 examples there. And the jury is sort of out on how much these 3D renderings, can they get to a high enough quality where they can impact diagnosis and they can help us. Jury's a little out on that, but some interesting examples. Now, we can't get into the ultrasound for fracture discussion without sort of looking at this. And I'll let you read this pro-con list, but I'll editorialize while you're reading it. So yeah, we're going to use ultrasound for fracture. Well, hey, we've got something for that. It's called X-ray. It's easy, it's good, right? It's a reasonable test, and it's kind of interesting from a few standpoints. So most of the point-of-care ultrasound literature for fracture that's out there uses X-ray as sort of the gold standard reference standard to establish test characteristics and accuracy. But when you start thinking about that, you start realizing, well, X-ray is a pretty imperfect test for a lot of these bones. And we know that, right, for the geriatric hip, for the scaphoid, for the proximal tibia, for the radial head. But even something as benign, if you will, as the distal radius, when you look at the studies comparing X-ray to CT, for those folks who get CT, the sensitivity falls around 90%. So we've got all these studies comparing ultrasound to X-ray as the gold standard. And our gold standard just perhaps is not that good. And it does depend on the anatomy we're looking at. Now, point of care ultrasound, like in many things, offers us a few advantages. We can have an efficient workflow. We can visualize concomitant soft tissue pathology. We can have increased sensitivity in certain areas, and I'll show you that. One of the cons, and I think this is a fair con, is the provider time. So if we're in there doing an ultrasound, and there's other things we could be doing, then that can potentially have a downstream negative side effect. However, this is where operational efficiency, workflow efficiency, and then potentially automated acquisition or something to help you do that could be in the cards. Okay. So looking at the technique, we'll go over technique, and then I'm going to jump into a few anatomies and show you those. But the technique is similar for a lot of these. We're going to be looking in the long axis view, if you will, or the sagittal orientation. That's going to help us pick up these fractures more than trying to go along it in the short axis view. We can use the area of maximal pain. We're going to survey over the anatomy, and we're generally going to take multiple views. So what are we looking for? Well, the big thing, and you folks probably know this, is that cortical disruption. So the bone should be nice and smooth, a nice echogenic line, and we're looking for a break or a disruption, and sometimes a step off, sometimes an angulation. Those can all be pretty helpful, and that's sort of what we can call our primary pathology or our primary finding of fracture. We'll talk about some other ones, though. The wrist is probably the best studied in this area, and we'll get into the pediatric wrist in particular, but most of the folks who have done this and put up literature on this use this 6-view protocol. And it kind of makes sense, and you could argue where if you're only tender over one spot, do you need to do the whole thing? And you could certainly have that conversation, but this is generally how folks will do it. It's sort of a dorsal volar radius view, dorsal volar ulnar view, and then the side views. And what folks will do, and I don't know that this blue rectangle is going to do what I want it to do, but kind of that sweep. So you start proximal or start distal, slide over, go up, slide back over, a little bit of that lawn mowing type thing to go back and forth across that bone as you're working up it. And this is sort of that in action. And we can see the operator going a few inches, stopping, sliding back and forth, few inches, stopping, sliding back and forth, and the distal radius image you would get. Now, you do have to be thoughtful and careful, I suppose, in that where you really want to do your interpretation is when this bony cortex is very clear, very obvious. As you fall off the bone to the side or you fan too far to the side, that's where you might have trouble and things get a little bit fuzzy or harder to see. Now, these can be obvious. These can be subtle. This is perhaps an example of a subtle distal radius fracture. But you can see it there. And with all things MSK, keep in mind, if you've got 2 arms, use that to your advantage. You can look at both sides and you can compare. But in this case, we've got a small cortical break of the distal radius. You can see that little bit of step off, a less obvious example. Now, the adult literature for the distal radius does exist. This is not all-inclusive. There is more than these 3 I put up here. But it's not a huge catchment. There's quite a bit more in pediatrics. So what we do have tells us that this is a sensitive and specific test. But certainly, I think there's opportunity for more growth in this particular arena. Peds gets a little more interesting. We get into a little bit more literature, and we've got some caveats. So what do we have unique to peds? We've got a growth plate. So we got to deal with that. We've got different fracture morphologies, the buccal fracture, so we got to deal with that. And then we've got cartilage, which can be pretty prominent. I'll show you an example, which can make it a little bit hard to interpret from the sake of joint effusion. Now, a few tips. The growth plate is generally going to have smooth, rounded edges. There's not going to be a step off in that these are going to be in plane, but you will see that. And again, if you're not sure, what do? Symmetry. You compare to the other side, and that's going to give you the answer. Is it abnormal or is it normal? The PEDS literature uses a similar 6-view protocol. And here we've got an example of a pediatric wrist where you can see the growth plate. I want everybody to notice there's this big area of black around that distal radius. So that, to me, might look like an effusion, and this is, again, symmetry to the other side. What that actually is the cartilage. So if you've been around pediatric joints at all, you will see that sometimes in the knees and the wrists and the elbows. I can assure you the 7-year-old whose arm this is did not have a broken arm. But that big area is cartilage there. And example of a buccal fracture, which I think that's slightly out of order, and that's okay. Um, Example of a study comparing ultrasound to X-ray. We can see our test characteristics down here. X-ray was the gold standard. And then these folks did, which I think is helpful, and a few studies have done this, and compared pain scores. One of the topics that comes up is, hey, you're going to put an ultrasound probe on the fracture. You're going to apply pressure. That's going to hurt. Is it going to cause more pain? And, nothing is perfect, and these pain scores are all slightly different. This one took into account the last dose of analgesia. Not all of them do. But what you find is the pain tends to be a little bit lower in the point of care ultrasound arm as compared to the X-ray acquisition, where perhaps there's a little more manipulation and movement actually required. Some big studies here, so 547 patients in the middle one, and we're getting very good sensitivity and specificities for the distal radius. Keep in mind that one in the middle is any fracture, not just distal radius. Now, who here has heard of the buccal trial? Anybody seen that one? That was a big one. So this is 2023 out of Australia. An individual who does a lot of this and puts up a lot of interesting, provocative work. And we'll spend a minute on this one. So this was in the New England Journal in 2023. And, I can't quite recreate his thought process. But if you look at this and you say, we know X-ray is not perfect. We keep comparing ourselves to X-ray. Let's do a functional outcome. Let's look at something that matters a little bit more and get ourselves away from the potentially inaccurate reference standard. And so that was the decision, was to look at what they called, or what is the PROMIS score, which is a functional, how well does your arm work? How much does it hurt? Can you do X, Y, and Z functional test? And they looked at that at 4 weeks, and they found no difference in the setting of an RCT. So in other words, these kids came in with potential wrist injuries, and they say, great, you're randomized to X-ray, you're randomized to ultrasound, and they did not do both on the kids. And they found identical outcomes. And I don't know who scribbled on the slide. I didn't do that. When I uploaded it, this was not here, and then the slides are actually reversed. It's a good lesson. Always go to the speaker ready room, because I was ready for it, but somebody got a hold of these slides. But they did, interestingly enough, they split it up, and this is probably worth doing. No fracture, buccal fracture, and then what they would call a cortical breach fracture or an other fracture. And the argument being that number 1 and number 2, because they are treated so similarly, we should separate those out from number 3, which is treated more with casting and more aggressive or more long-term therapies. Now, did anybody see the Annals of Emergency Medicine article that came after this one? It was the same data set, and it was another clever thing as far as getting 2 really good publications from the same data set. But what they did with that one was they looked at the X-ray findings as sort of a secondary outcome, but instead of putting it in the same paper, they put it in a separate paper. Okay, so that's in Annals of EM, and what they basically had there was the ER physician would, during the actual study, interpret the X-ray or interpret the ultrasound as they were going through, and then they had a panel in this study of 3 different reviewers who would look at all the information. And again, not everybody had X-rays and ultrasound. Most people just had one, but they had follow-up visits, they had clinic notes, they had other stuff, and they would come to a consensus on what the final answer was. Was there a fracture, no fracture, buckle, no buckle, etc.? And the accuracy in the ultrasound arm was on the order, and I wrote it down because it's not in here, but on the order of 98%, whereas in the X-ray arm it was 83%. And so they would make the case, hey, we've been comparing ourselves to this gold standard of X-ray. This is actually a lot better than X-ray. So we need to sort of perhaps reverse what is considered the gold standard. And so provocative and interesting. Examples for you. A buccal fracture, a cortical breach fracture. The difference here is there a break in the cortex? So in other words, is the cortex discontinuous versus, just like you would expect with a buccal fracture, irregular but not discontinuous? Okay, we're going to jump into questions so far, folks. I'll pause for questions perhaps. Okay, we'll jump into secondary signs because this gets interesting too, and this is where ultrasound starts to show its legs perhaps even more. Yes, we can find the bony cortical disruption like in this skull fracture, but we can also see the periosteal hematoma, that little collection of blood around that bony cortex. That can do a few things for us. Number 1, it could perhaps increase our detection of that fracture if we hadn't seen it already. And number 2, it can increase our certainty that, hey, there's this little irregularity in the cortex. I'm not sure. Sometimes I see that. Well, now that I've got this big periosteal hematoma, I can be pretty sure it's specific. And this is, again, best studied in peds in the pediatric forearm. And yeah, yeah, a lot to unpack here, but just briefly, they tried to look at which of these secondary signs helps you distinguish between no fracture or buccal fracture and cortical breach fracture is the short story. And they found that some of these are pretty useful. I'll draw your eyes to the specificity of a periosteal hematoma or an angulation. They looked at one of the muscle bellies in the forearm and said, you know what, when this thing is thickened and there's a hematoma in there, that indicates a cortical breach fracture. And they looked at distance of the fracture line from the physis and said whenever it's less than a centimeter, that's a Salter-Harris 2 fracture. So they did some interesting things there that tended to work. Okay, we're going to jump into scaphoid real quick because I think it's interesting. And this, you know, we all know the workflow here. Thumb spica, follow up. There's a little bit of a pain point there. And of course, there's pretty interesting literature that says if you just do an MRI or a CT in the ER, you actually have cost savings associated with that. But of course, from an operation standpoint, we can't really do that. So it's neat to like read the paper and say that that's cheaper, but then we realize we can't really do it for the sake of the waiting room and all of those things. The scanning process that's described here is not as intimidating as you might think. So you're going to dorsally, ulnarly deviate the hand. That's going to open up the scaphoid. You're going to take images from the volar standpoint and the dorsal standpoint, and you're looking for that same thing. Is there a discontinuity in the bony cortex? And then secondarily, it can be helpful. Do you see an effusion or do you see any black basically on top of this bone? And we're going to move through a few things, but the literature here is interesting. One study, only 5 fractures, 100% sensitivity. Another study, bigger, I forget the exact number, but bigger, again, 100% sensitivity. But that's not all of them. This one, the accuracy and the test characteristics of ultrasound were a lot better than X-ray, but perhaps not good enough, but perhaps not that 100% number. So the jury's a little out on the scaphoid. I think it's an area that would be great for more research, especially ER docs doing it, and to see what the test characteristics are if we really pay attention to it. One of these papers with 100% sensitivity did have this flow diagram in it, sort of making the argument that, hey, if you know what you're doing and you do this and you don't see anything on that scaphoid, you can go ahead and say no further examination, right? So provocative, I think. Fracture reduction is another interesting one. If you haven't seen this one, and this is an interesting paradox because we do have, where you have fluoro, that's a pretty good test for fracture reduction. But as soon as you step out of tertiary care centers, ortho residents, those kind of things, you start to find, and I'm sure this is not universal, but you start to find that fluoro starts to disappear, if you will. And you're left with sort of the classic, is it reduced? Do we try to get the x-ray to come while they're still on the finger traps? Do we put a splint on it? Do we have to do it again? These kind of things. And it's a good use case, and I encourage you to think about it for shoulder reductions and hip dislocations too. There's so many times the ortho resident's pulling on the hip, and I think I got it, and I think I got it. And you can just look at the hip joint, if you're familiar with that anatomy, and say, yes, it's in, we're done, or no, we're going to keep doing sedation. So similar to that potentially. And a lot done here on this. And it looks like that one's backwards, but this is just a systematic analysis looking at rate of fracture reduction success. And you can see most of the time in the 90s, folks do pretty well with using ultrasound to predict, is it going to be a post-reduction success on my post-reduction x-ray? So this, the usage here, as soon as you do a little distal radius ultrasound, the usage here is not at all hard. You're going to look at those two views, posterior and radial side view, and you're going to look for bony alignment. And you can look for radial shortening. That's one thing. So where the radius comes over the more proximal radius. And then you can look at these angles where the distal radius fragment is dorsally displaced upwards. And you can watch that angle come down and sort of be reassured that your x-ray is going to mimic your ultrasound. And it kind of makes sense. If you've got that bony anatomy visualized, you bring it down in line, it should on x-ray look similar. And that does seem to be what happens. A study comparing ultrasound guided versus fluoro in kids, both arms seem successful. And then an RCT, though, with a little bit less success, although if you look at the absolute numbers of more than one attempt, they were small, and there were still twice as many on the standard reduction side, although the odds ratio did cross. So take that as you will. All right, getting to the end, folks. Lots of other pathologies here. We know about ribs. We know about the sternum. The hip, I think, is particularly interesting if you haven't run into any of this before. So this is way back in 2009. It was only 30 patients, 10 of which were fractured. But they basically said, you know what? Every one of these hip fractures, and they did this prospectively, but every one of these hip fractures either had an effusion, because it involved the joint capsule, or had fluid around the greater trochanter, around the greater trochanter bursa. And the patients who had neither of those, as well as I think a third factor of no clear cortical break on the ultrasound, did not have a hip fracture before they went on to get MRI to prove whether they were correct or not. These folks did this again more recently. They did a bigger study on hip ultrasound, all comers for people getting x-rays. But the ones you really care about are there were 13 with false negative x-rays, and all of them were picked up by ultrasound. And this was one from our institution, which is interesting. You know, they got an x-ray, it was negative, suspicion was fairly high. And not wading into the should you get a CT or an MRI for a occult hip fracture, leaving that aside, this individual got a CT, which was still negative, and so now it's super awkward, right? Because you've already sort of really kicked the can. And we went ahead and looked, and we saw this hip joint effusion, and then we saw what looked like a cortical break here. So we did push this to a third test, MRI, proved the femoral neck fracture, admitted surgery, etc. So can be something, I suppose, in this case, very specific if you know what you were, if you knew what to look for. And it's the same. It's nice with the hip effusions because if you've done that for septic arthritis evaluations or gout, it's the same view. It's mostly the same pathology. So it can be pretty easy to do. We're going to roll through the ankle, interest of time. The only thing I'll say about the ankle is every now and then, and this is not common, but it does exist, you may find something, and in this case what I'm trying to show is an Achilles tendon rupture, which may hide from that x-ray. And of course the critique here is, hey, the Thompson's test is very sensitive, but the counter to that is you got to know to do the Thompson's test. If you're not thinking about it, you can miss it. And the nice thing about using ankle ultrasound potentially for your fracture evaluation is you've got it right there, and you can use it to detect that secondary soft tissue pathology. All right, interest of time, folks, I'm going to pause there. Questions, comments, and thank you for your attention. Yes?
Have you thought about, especially for the wrist joint, doing underwater test?
Yeah. So basically, sorry, the water bath to allow you not to have to touch it. Yes, that can work. It depends on the kid's arm and exactly how things are angled, because it can be tough to get everything submerged. Now, if you have a short enough kid and a big bucket of water and they can angle it, and you mimic that angle with the probe, that works great, and then you don't have to apply pressure. Anecdotally, I'm always concerned about the pressure and always worried that's going to hold up the exam. It doesn't tend to. Our experience is similar to what the literature's shown, which is that it's just a little less painful than x-ray, and that's probably because you can use a big gel pad, you can use a water bath, you've got options, and you don't have to bring this great x-ray gantry over to get that true lateral and the oblique and those kind of things. Yes, sir.
I feel like this is probably giving, especially in the pediatric world, a new thing that we don't want to do because tens all like no radiation, right? So for like Salter Harris fractures, is there any like implications on that? Because we just see a cortical disruption, but you're worried about plate involvement and that other stuff, classification. Is it more of a screening that you're using to
I think so.
Give you that, that reason to get the x-ray?
Yeah, I think that's exactly right. I think where the literature is currently is, do they have a cortical breach fracture or do they not? And if they don't, no x-ray, you're good, going home. If they do, then that might be the time to get the x-ray and define the degree of the Salter Harris. Now, that probably is not the end point of this literature, but that's probably where it is right now. Yeah. Yes, sir.
I'm excited to try some scaphoid ultrasounds. Is there cartilage there that we need to worry about if I make the fusion?
Yeah, it's a very, very thin layer in adults, tiny, tiny little black stripe, so it shouldn't throw you off, and it shouldn't, chance of false positive for an effusion, I think, is low. Again, any doubt, you just look at the other hand. You look at the uninjured hand. Now, with wrist joint effusions, including around the scaphoid, any amount of pressure can sort of, quote unquote, compress those effusions and move that fluid to the other side of the joint. So to avoid a false negative, you want to make sure you're not really pushing in, because you may make that fluid disappear. All right, well, thank you, everyone.